Welcome, everyone. My name is Mary Marinowski. I'm a registered dietitian in medical affairs with Nestle Health Science, and I'm delighted to have the opportunity to introduce today's speaker and assist with the webinar entitled Advances in Surgical Immunonutrition. I am very pleased to present today's speaker, Dr. Juan Ochoa Gautier. Dr. Juan Ochoa Gautier completed his first general surgery residency training program in Colombia and graduated with honors. He later came to the United States to continue his training in surgical research and finished a second residency in general surgery and a fellowship in critical care at the University of Pittsburgh. Dr. Ochoa Gautier served as a tenured professor of surgery and critical care at the University of Pittsburgh and Associate Director for Trauma Services within the UPMC system. He maintained an NIH-funded laboratory throughout his academic career, focusing his work on studying arginine metabolism. As a physician scientist, Dr. Ochoa Gautier's work spanned the translational spectrum, with significant contributions in the basic understanding of arginine depletion and better definition for the phenotypical and functional effects of arginine deficiency on T lymphocytes and nitric oxide production. Dr. Ochoa Gautier is the Chief Medical Officer for Nestle Health Science North America and continues to participate in academic pursuits, maintaining a limited clinical practice in critical care at Geisinger Medical Center. He continues to perform research and has published over 110 manuscripts in peer-reviewed medical journals and chapters in major reference books. He currently lectures nationally and internationally, passionately advocating for the optimal nutritional care of all patients. Without further ado, welcome Dr. Ochoa Gautier.
Thank you so very much, Mary, and I welcome every one of you. It is an honor to be here, and I appreciate that it is an effort on your part. So let's dive into this exciting topic today, and let's look at what is new in surgical immunonutrition. I do have three objectives that will take us through a number of important areas that we need to discuss. The first one is I will go over the clinical benefits of what is called efficacy, that is, of prospective randomized controlled trials, as well as evidence of effectiveness, that is, in the real world, is the product and is immunonutrition working. I will also describe the mechanistic aspects of how immunonutrition works to improve clinical outcome. What is the mechanism of action? And then I will look at a related topic, which is that of immunonutrition formulas do contain other nutrients, including that of carbohydrates, and how these formulas need to be updated, particularly with the knowledge that we have gained on the damages with excess carbohydrate loads that can occur in surgical patients. So I invite you to dive into this program. Let's look at the clinical evidence. In 2011, John Drover, Darren Hyland, Rupinder Dhaliwal, Paul Wishmeyer, myself, were asking the question as to whether we should be performing a large prospective randomized control trial on looking at immunonutrition in surgical patients. And before we did that, we did this meta-analysis and collected 35 prospective randomized control trials, 25 of them in GI surgery, and almost 3,500 patients. And we evaluated the use of arginine-containing products on outcomes. What we found was very consistent, and that was about a 41% reduction in the risk of infections in the surgical patients post-operatively. We also found a secondary outcome that was important, which was that of a reduction in length of stay. Mortality, interestingly, was not changed. And then we dove into a little bit of what we called sub-analyses, and let's look at infections under certain circumstances. So this graph It's part of the figures of the article that we published in Jackson Journal of American College of Surgeons in 2011. And what you see is a green dotted line called the point of unity. Anything that falls to the left is favoring the use of arginine and arginine-based immunonutrition. The diamond denotes the average, and the horizontal line denotes the range. And so what you see is that we were able to look at 21 studies in gastrointestinal surgery, and we found a 40% reduction in the risk of infections in those patients. Non-gastrointestinal surgical studies were also identified, and again, we saw a significant benefit. It didn't matter where in the gastrointestinal tract, whether it was in the lower gastrointestinal tract or upper GI tract, it didn't matter, the benefit was there. And it was very important to identify that independently, the use of arginine-based immunonutrition was beneficial if used preoperatively only or postoperatively only, but that the largest benefit from the use of immunonutrition was if it was used before and after surgery. Now, it is interesting to observe that only the formulas that contained arginine, fish oil, and nucleotides appear to work, while other formulas that were called immunonutrition formulas were not working. Let's dive a little bit deeper into that. And so normally I do not present any slides that have commercial names in a slide, but because these were the formulas tested in different studies, it is important to look at them. And what is important is to look at the formulas that are not all the same. They are actually quite different, and therefore we cannot just put arginine supplemented formulas into one bag and think that they are going to work the same. Formulas such as IMPACT and IMPACT Advanced Recovery do contain nucleotides that other formulas do not have, and that becomes significantly important. They don't contain glutamine, which another one of those formulas does have, and they tend to have a higher arginine concentration than other formulas. And so it is important to realize that there are significant differences. Now, the wonderful thing of surgical immunonutrition is that we have now been able to simplify this to clear protocols, and as I will show later, to incorporate immunonutrition into what we call enhanced recovery programs and bundles. The dosage that needs to be given to patients ideally for them to see the benefit is to give them 5 to 7 days prior to surgery, giving 3 cartons a day, and at least 5 to 10 days postoperatively, giving again 3 cartons a day. And the sooner you start after surgery, the better. This, as we saw in John Drover, gives us the best results. But let's see some studies. Now, before we do a look at the studies, it is important to say that the use of surgical immunonutrition and arginine-based immunonutrition is now an accepted form of nutrition intervention. And it is supported by critical care nutrition guidelines, and there is currently really no controversy on this. And so, as you can see, immune-modulating enteral formulas, as they call them, containing arginine, should be considered for perioperative use in and out of the surgical intensive care unit, including giving that in postoperative patients. Where there continues to be some controversy is the routine use of immune-modulating enteral formulas in severe sepsis. And in the current guidelines, and I agree with them, it is not suggested to give these formulas in severe sepsis. The big and significant change in clinical practice in surgery that was incorporated into the guidelines is the avoidance of prolonged starvation postoperatively. So it is suggested that patients are allowed to eat as soon as possible. Now let's look at this. This is a case study. This is real-world data. This is a work performed by Bertrand and colleagues in patients undergoing radical cystectomy. And as you see, these patients received preoperative immunonutrition. They used 30 retrospective match controls to compare. And what you see is that very consistent results, very similar to the prospective randomized controlled trials, a significant decrease in complications, a significant decrease in paralytic ileus, no change in deaths, and a significant decrease in infection rates. Let's look at another study, also real-world study. In this case, this work was done by Nick Rowan and Jonas Johnson at UPMC, and it was done in head and neck cancer patients. And they received arginine-based immunonutrition prior to and after surgery. And what you see is a significant reduction in complications and a significant reduction in pharyngeal leaks and fistulas. And this is highly consistent in patients undergoing head and neck surgery, particularly those patients that have skin or skin and muscle flaps. Not surprisingly, there was also a significant reduction in length of stay in these patients. The third study that we can see that is also recent in the last 2 years is that of the use of postoperative enteral immunonutrition in patients undergoing gynecologic surgery. And what you demonstrate again and again, highly consistent with all the literature, is a 41% reduction in the risk of surgical site infections compared to the controls. But as importantly, and this is observed in a number of studies, even the patients that do not, where you cannot completely prevent an infection, even in those, the severity of the infection is significantly lower, and those patients need less resources, less readmissions, less and have a less severe course. So there's a benefit. Whether you get or not get an infection, there is a benefit to patients that do get an infection despite the use of an immunonutrition. In the last 8 years, as the cost of care has become quite difficult to manage, there has been this concept of quality improvement, that is delivering better care at a lower cost. And to do that, clinicians have created what are called enhanced recovery protocols or bundles, where different interventions that are known to work on their own are instituted as a group of interventions. And what are those enhanced recovery protocols? They are used preoperatively, postoperatively, and intraoperatively. And they are different types of interventions, including, for example, adequate pain control postoperatively, or the use of adequate amounts of IV fluids intraoperatively. Nutrition has a really important role. That is the use of immunonutrition perioperatively, the use of what is called carbohydrate loading, which I will be talking about, and then early oral nutrition with immunonutrition. The American Society of Enhanced Recovery, ACER, is one of those societies that has been working on quality improvement in the creation of enhanced recovery protocols. And what they recommend is to reduce preoperative starvation period by using carbohydrate loading, which may be given 12 hours prior to surgery and up to 2 hours before anesthesia. They also recommend the use of immunonutrition that contains supplemental arginine, omega-3 fatty acids, and nucleotides, given 5 to 7 days prior to surgery and 5 to 10 days after surgery. ERP bundles do work, and they work in colorectal surgery, and they work in other patient populations such as hip surgery and others. And these bundles have demonstrated that they can reduce complication rates by 30 to 50% and reduce length of stay by 2 or 3 days. Now, it is important that the bundles have to be strictly applied. There has to be compliance, and you cannot pick and choose from the different interventions in the bundle. So you cannot just create your own bundle. Interestingly, the use of carbohydrate loading around the time of surgery is associated with benefit only if it is given within a bundle of care. Outside a bundle of care, carbohydrate loading has shown no clinical benefit, even though there appear to be some biochemical benefits stemming from it. And so, again, the protocol becomes quite simple. Give preoperative immunonutrition, 6 days, starting 6 days prior to surgery for 5 days. It is completely compatible with carbohydrate loading. They work through different mechanisms and they support each other. So you do not have to select one form of nutrition versus the other. Then after surgery, start as soon as possible with your surgical immunonutrition protocol and your arginine supplemented immunonutrition. Multimodal therapy and bundles have extended to hip surgery. And the Acerto is just another group, in this case in Brazil, which has demonstrated a benefit for the use of arginine immunonutrition. In this case, hip patients were subjected to surgery, and what you see is that the patients that received arginine-based immunonutrition had a significant decrease in the inflammation that occurred after surgery. Now this appears to be just modest, but we know that decreased inflammation is associated with significant benefits, including the faster recovery in ventral hernia repair. We can also use bundles, and bundles have become a significant issue. Now, there were several 100,000 hernia repairs and incisional hernia repairs in this country alone. And they have a significant amount of morbidity and even mortality. So even though they appear to be relatively trivial as surgery, they are actually quite complex. What you see with the use of a bundle that incorporates arginine-based immunonutrition is a 75% reduction in readmission rates. And so one of the important and newer issues that is arising and data is collecting very fast is the benefit of arginine-based immunonutrition not only during the time that it is given for the patient after surgery, so not only during the time that the patient is in the hospital, but it extends up to 30, 90, and now some studies are looking at even a benefit at 180 days or more from the use of these diets. Here is another study that now extends the benefits of arginine-based immunonutrition up to 3 months. In this case, this was a single-blinded, prospective, randomized controlled trial. It was done as a pilot trial in patients undergoing cystectomy, a good number of them that had laparoscopic procedures. What you see in these patients is a significant reduction in antibiotic use in the first 90 days after surgery, and a significant benefit in anti-inflammatory effects not depicted here. So how does immunonutrition work, and why is the surgical patient so benefited by it? The mechanisms have now been worked out, and they are actually quite simple. There's no magic to this. And I will take you through several slides that complement each other and some slides that just will give the message that all we are looking at about and all we're talking about is that of the fact that surgery is associated with a depletion of arginine, and that depletion will lead to dysfunction in T lymphocytes and will lead to decreased nitric oxide production and decreased tissue oxygenation. T-cell dysfunction and immune dysfunction will lead to an increased risk of infection. Decreased nitric oxide production increases the risk of wound breakdown and subsequent infection after that. And let's dive a little bit more into that. What we discovered in our lab a number of years ago is that both human beings and in animal models of surgery, there was a very rapid decrease in arginine plasma levels. In fact, in a mouse model of a laparotomy, within an hour, the mice lost about 50% of their circulating arginine, and within 4 hours, 90% of the circulating arginine was gone. the only way to explain that loss of arginine was to identify and to find, and we eventually did, found an increase in an enzyme called arginase 1. And this enzyme is responsible for converting arginine to ornithine and urea. Later, we discovered that this enzyme was contained in some cells that had never been described before and that eventually got the name of myeloid-derived suppressor cells. And these cells are unique in their mechanisms of immune suppression, as I will show. Myeloid-derived suppressor cells are an immature group of cells. They have a lot of heterogeneity. That is, they have many different characteristics. A good number of these myeloid-derived suppressor cells contain the enzyme arginase, and they are quite active at depleting arginine. By depleting arginine, they regulate T lymphocyte function, as arginine is an essential nutrient for T lymphocytes, as I will show in the next few slides. By doing that, myeloid-derived suppressor cells profoundly suppress the immune system and increase the susceptibility of surgical patients to infection. Jill Hamilton gave us evidence that arginine-based immunonutrition not only restores arginine levels, it also regulates myeloid-derived suppressor cells, possibly through a combination of omega-3 fatty acids and nucleotides, along with the arginine that is also there. And what you see is, you see this bump in myeloid-derived suppressor cells today after surgery. This is very consistent. It's consistent in human beings, consistent in mice. And what you see is that patients that had taken arginine-based immunonutrition 5 days prior to surgery had a significant benefit and a significant decrease in the accumulation of circulating myeloid-derived suppressor cells. It is thus really important to point to the fact that the benefits of arginine-based immunonutrition given pre-operatively extend into the operating room and can be identified and extend into the early post-operative period, where we could not achieve that if we were using only post-operative immunonutrition alone. And here's the data that we collected many years ago in our laboratory. In the x-axis is increasing concentrations of arginine in the culture media. We have two lines that depict two different types of T lymphocytes, CD4s or helper T cells and CD8s or killer T cells. And on the y-axis is proliferation. And as you see, in the lower doses of arginine, when arginine is deficient, there is a dependency in proliferation. That is, proliferation is significantly negatively affected by the low concentrations of arginine. It is only when normal arginine levels are reached in the culture media or in plasma, and by the way, these are the same levels that you see in a normal person in plasma, that you achieve normal lymphocyte function. And thus, arginine is really important for T-cell proliferation. It is important for memory formation, for the capacity of T lymphocytes to kill, to proliferate, to produce cytokines such as interferon gamma. All of those are negatively affected by surgery. Now, interestingly, all of these processes are also affected by certain cancers. By providing immunonutrition, we restore immune function and decrease the risk of infection. And this is a pharmacokinetic proof that indeed we enrich plasma levels of patients that receive immunonutrition. In this case, we tested new formats of arginine-based immunonutrition, one in a lower volume with lower amounts of carbohydrates, as will be described below. And what you see is that we got an enrichment in plasma arginine that was very nice and that was sustained for up to 12 hours or longer. So a very nice response. It is very important to look at this type of data when you're going to use, and know that it exists when you use immunonutrition. Why is that? Because it is not only the enrichment in the plasma that is important. And I realize that some people criticize the use of immunonutrition preoperatively because the half-life of arginine is somewhere around 6 to 8 hours. However, what is very important is that arginine does accumulate and concentrate inside the T lymphocyte. This was demonstrated recently by Antonio Lanzavecchia in activated T lymphocytes. And what he showed was that as he increased the levels of arginine, both done in in vitro experiments or in vivo experiments, he could observe an accumulation of arginine inside the T lymphocyte, and that allowed the T lymphocyte to continue to work better even when arginine levels started dropping outside of the cell. And so T cell survival was sustained for 7 to 10 days with this arginine enrichment. But that's not the whole story. Arginine is also essential for normal vascular function. In 1987, it was discovered by 3 different investigators that arginine was the precursor for this magical compound called nitric oxide, and that nitric oxide was produced in the endothelium, and that as a physiologic effect, it produced significant vasodilation. And so when we run out of arginine, our endothelium cannot work well. And there is suboptimal vasodilation and suboptimal oxygenation. So one of the significant limiting factors and one of the significant predictors that our anastomosis and that our wounds are not going to do well is that of limitation in blood flow and oxygen delivery. In fact, we know that that is the most significant factor and the most significant predictor as to whether a wound that we create in the operating room or an anastomosis that we create is going to heal or break down. We know that around 5 to up to 18% of anastomosis break down, and that can be a disaster. And we know that when we raise flaps such as musculocutaneous flaps in head and neck cancer surgery, what we see is a tendency to necrosis, ischemia and necrosis of the tips of those flaps, creating real problems. Marco Braga provided an elegant documentation of the effect of pre- and perioperative arginine supplemented immunonutrition. What he did in this double-blinded prospective randomized control trial in well-nourished colorectal patients is he created 4 groups: those that received preoperative immunonutrition only, those that received perioperative immunonutrition, those that received an isonitrogenous isocaloric control, and those that were managed conventionally as most and many surgeries are done routinely. And what he showed was a significant decrease in infection rate and a decrease in length of stay. But that's not the new news. We know that. What is important was the effect on tissue oxygenation. And he was able to put a probe on the colon during surgery, at the start of surgery, and he kept it there for up to 7 days. And he was able to measure gut oxygen tension for all of those days. And what you see is 4 lines following the 4 groups of patients. The blue and the green line show patients that received arginine supplemented immunonutrition prior to surgery, and the green prior to and after surgery. And what you see is this magical number of 60. 60 depicts the place where the hemoglobin achieves lower and lower saturation, and we as physicians do not want to see oxygen tensions lower than 60. You see that even at the start of surgery, and that is why this is so important. Even at the beginning of surgery, if you were loaded with arginine supplemented immunonutrition, you were deriving a benefit, and this benefit was maintained for 3 or 4 days. If you received arginine post-operatively also, so perioperatively, you saw a further benefit in these patients. This last did not achieve statistical significance, but if you can see it, there is an obvious difference in benefit of patients receiving perioperative arginine supplemented immunonutrition on oxygen saturations. So in summary, This patient's, these formulas and arginine supplemented immunonutrition along with nucleotides and omega-3 fatty acids increase tissue oxygenation not only at the level of the anastomosis but also at the levels of the skin flaps and probably systemically in our surgical patients. And through this second mechanism, they further improve clinical outcomes. But remember, this is not all the story. It's not only about arginine. Omega-3 fatty acids are essential. Arginine supplementation only does not work and has not shown a benefit in clinical studies. You have to mix it with omega-3 fatty acids and with nucleotides. We know that EPA and DHA are important in regulating and minimizing an inflammatory response. They are also important at controlling the signals that induce myeloid-derived suppressor cells and therefore preventing the upregulation of myeloid-derived suppressor cells. And they do increase T lymphocyte function. They interact with arginine. We showed that, and it work done by Vishal Bansal and Kim Sayers in my laboratory a number of years ago. And this is what is called a Western blot, which measures the amount of protein. The darker the blot there, the more protein there is. This is an internal control showing a nice big blot, and what you see is a progressive increase in arginase activity in this Western blot. The darkest blot is depicting the cells that receive prostaglandin E1, that is derived from borage oil, and IL-13, which is a cytokine. The intermediate amount is those cells that receive prostaglandin E2, derived from corn oil, plus IL-13, and then the blunted response was seen with fish oil, with prostaglandin E3 derived from fish oil and IL-13, demonstrating that indeed fish oil could potentially blunt the arginase response. Interestingly, in these same experiments, nitric oxide production was inversely proportional to the amount of arginase induced in these cells. So arginase expression may be modified by the type of fatty acid that the patient is supplemented with. There's one more important issue of why it is so crucial to give arginine supplemented immunonutrition before surgery, and that is that there is a widespread omega-3 fatty acid deficiency in the United States, particularly in patients that are 50-year-old and have a risk factor such as hypertension or obesity, which unfortunately is very common. And in this case, what is called the Vascassen trial by Psych, what was demonstrated is that 89% of the patients that were screened had severe deficiencies in omega-3 fatty acids measured by what they called the omega score. What about nucleotides? Nucleotides are gaining more and more attention. They are really building blocks for DNA and RNA. They're indispensable in stress states, and they are essential for rapidly replicating cells, including those of the intestine, including the immune system of the intestine and immune cells in other places. It is really important that we can make our own nucleotides, and in fact, T lymphocytes make nucleotides when supplemented with arginine. But what we have is a second pathway, which is called a salvage pathway in these cells, and that is these cells can use nucleotides that have been previously created and avoid the need to make its own nucleotides and therefore save themselves the effort. And so what is supplemented is a yeast extract with nucleotides and arginine supplemented immunonutrition. Let's move away from the immunonutrients to the rest of the formula. It used to be 20 or 30 years ago when I was starting to work and doing my residency training that we believed that trauma patients and surgical patients should receive high amounts of carbohydrates. We now know that that was a mistake, and we know that patients that undergo surgery and have hyperglycemia have poor outcomes. In fact, the poor outcomes are proportional to the number of hyperglycemic events, as you can see. And thus, it is really important to control blood sugars, and adequate blood sugar control has become a marker of good quality of care in the surgical patient. It makes no sense with this knowledge now to load the patients with high amounts of carbohydrates in the diet, as we will actually increase the risk of hyperglycemia, particularly postoperatively. And so what we did was to decrease carbohydrate loads significantly. And what you see is there is a far better glucose control with the lower carbohydrate load formula than with the conventional formula, and lower insulin levels in these patients. So in summary, what we have is an exciting landscape that demonstrates more and more that arginine supplemented immunonutrition, along with omega-3 fatty acids and nucleotides, is alive and well, and that it is benefiting patients, and that there is currently no doubt that there is a benefit in reduction of infections, in better wound healing, in, as we saw, in lower inflammatory rates, and that these benefits extend beyond the time that they are in the hospital. These benefits also extend to what we call health economic benefits. There's lower readmission rates and lower cost of care of these patients. All of these three immunonutrients have a mechanistic role. They are important and in fact essential, and when we take one of these out, there is no beneficial effect on these patients. Our knowledge has expanded significantly to understand that immunonutrition is more than just an effect on immune function. It is also a benefit on the endothelium in the vascular system, with increased increased oxygenation, which particularly at the level of the wounds, and better wound healing. Finally, we know that when we give arginine supplemented immunonutrition, we also give regular oral nutritional supplement diet. It is important to control carbohydrate loads in these patients, and therefore it is important to reduce the carbohydrate amounts that are given to these patients. I want to thank you so much for your attention, and I hope to listen to any questions, and we'll be delighted to answer them. Thank you so much.
Thank you so much, Dr. Ochoa, for that excellent presentation. We have received some questions from the audience already, and I think more are coming in at a fast clip here. Our first question for Dr. Ochoa is, in regards to unplanned emergent procedures, is there a benefit of immunonutrition post-op in these patients?
There is, and it does depend on the type of patient. So if the surgical patient is a septic patient, again, the guidelines recommend being cautious about it, and it's still controversial. But as a patient is a trauma patient, or is a patient that came for a non-infectious surgical emergency, there is a benefit of giving these patients arginine supplemented immunonutrition postoperatively. It is not as big, it is not as significant as if we gave it prior to and after surgery, but it obviously is impossible in these patients to give, to plan to do that beforehand.
Okay, thank you very much. Here's our next question. Are you aware of any reports of hyperglycemia in surgery patients with diabetes using a formulation that would have 45 grams of carbohydrate per serving?
Remember, a glucose tolerance test is between 75 and 100 grams. And in fact, in some patient populations, we reduce glucose tolerance tests to 50 grams. And yes, in patients that are prone to that, we indeed could see a significant bump in glycemias. It may well be that if the patient is a patient that is normal and is not having any insulin resistance, that patient can tolerate 45 grams of carbohydrates without trouble. But you don't know what the patient is going to do, and you do not want to test that idea in the first or second day post-operative.
Okay, thank you very much for that. And the next question is, if immunonutrition is given preoperatively, but if the patient's kept NPO or on clear liquids postoperatively, how much benefit is there?
So what we noticed is that the preoperative benefit was somewhere around 25 to 30% reduction in the risk of infections, up to 34%. When we combined prior to and after surgery, it was 41% reduction, and that was statistically significant. And if we gave it postoperatively only, the benefit was 22%. Also statistical significant benefit, but also significantly lower benefit than if we did the ideal prior to and after surgery. So I do encourage people to start postoperative immunonutrition as soon as possible, when allowed and if allowed by your surgeons.
Okay, thank you. Dr. Ochoa, your presentation described reduction in risk of infection when you talked about the Drover meta-analysis. How was risk defined, or was this a comparison of incidents?
It was a comparison of incidents. What we do know is that there is a decrease in infections, both locally, that is in surgical site infections, locally in the wounds, and distantly, such as urinary tract infections or pneumonias.
Okay, thank you very much for that. We have had a couple questions here about post-transplant patients in terms of the use of formulas containing arginine, fish oil, and nucleotides. Are they helpful in post-transplant patients that are on immunosuppressive medications?
The answer is we don't know. And I would love to do that study. There are pros and cons, obviously, in this patient population. If we maintain or enhance T-cell function, we might potentially get a rejection. But at the same time, we do not want to have an infection in these patients, and we do want their wounds to heal. So a little bit of a catch-22. What we do know is that there are some observations in animal models and a human observation that suggests that arginine and omega-3 fatty acids at least could be safe. However, we do not have enough data right now to recommend the use of arginine supplemented immunonutrition at this time.
Okay. Getting a fair amount of questions here on nucleotides as well. Why do we think nucleotides make a difference in the immune response we get from gut-associated lymphoid tissue?
So there are a number of potential mechanisms, and we still have significant gaps in knowledge. We do know, however, that they appear to be essential in these diets. A couple of different mechanisms that have been suggested. One is that they provide what are called distinct nutritional requirements, that is the limiting nutrients for the proliferation both of mucosal cells in the gut and of immune cells both in the gut and systemically. And in fact, there is an article in 2009 that demonstrates that when patients receive arginine supplemented immunonutrition, you do see an increase in circulating uracil levels. And yet another mechanism is that of inducing what are called TLRs, which are these receptors that help the immune system be alerted as to preparing itself to fight a possible infection. So those are just three possible mechanisms. There are most possibly more, and we desperately need more research in this area.
Okay, thank you very much for that. Would these supplements, and I'm assuming that this is a question about immunonutrition, be helpful for patients having thoracic surgery for lung cancer? This person that's asking the question has tried to tell a thoracic surgeon about it, but the surgeon said the risk of infection of lung surgeries is low.
There is so far no surgical patient population that has been studied that has shown a lack of a benefit. We now have head and neck, we have cardiac, we have gastrointestinal, we have urologic, we have now beginning to collect orthopedic surgery data. the question is whether we will collect data for every type of surgery or not. And so there is, I have to agree, that there is insufficient data in thoracic surgery. The benefit is going to be there, whether the incidence is low or not, but the benefit is going to be there. It is just going to be more difficult to detect if the incidence of infection is low. But the incidence of other complications is quite high in thoracic surgery. And so the surgeon and the clinician and the dietitian are going to have to weigh the pros and cons of using a potential a formula, an arginine supplemented immunonutrition formula, in the absence of data that is specific for that patient population.
Okay, thank you very much. Our next question is there a significant difference in the outcomes when patients are given high protein supplements versus immunonutrition?
Yes, there is a difference, and this is really important. Immunonutrition does not work only by providing protein for to prevent and or treat malnutrition. In the prospective randomized controlled trials, there is an adequate isonitrogenous isocaloric control. So that means that it delivers the same amount of protein, and yet you see a consistent benefit that is, again, around a 40-41% decrease in the risk of infections and decrease in the risk of other complications. So there's a difference beyond that of just providing protein.
Okay, thank you very much. Our next question has to do with the slide that showed the appearance of plasma amino acids following consumption of 2 different immunonutrition formulas. And the question is, was the area under the curve statistically significant between the formulas when it comes to the appearance of plasma amino acids? And in this case, I think it would have just been arginine.
Yes. No, because these formulas, we were comparing whether these 2 arginine-containing formulas would enrich plasma, and the arginine plasma levels would be enriched by these 2 formulas, and whether by reducing volume and reducing carbohydrate loads, whether we would alter the absorption of arginine. And so in the 2 formulas, you get a very nice enrichment of arginine. It is not different at all between one formula compared to the other.
Okay, thank you for that. We have a number of questions in relationship to carbohydrate loading, and I'm just going to try to summarize them here. The person that's asking the question is commenting that sometimes maltodextrin solutions are used, and other times, I don't want to say any brand names, but let's say sports drinks are used as a source of carbohydrate. Do you have an opinion on what is chosen?
So there's a meta-analysis that suggests that it doesn't really matter. However, if you look at it biochemically, there are biochemical differences. Maltodextrin at the end is glucose, and it will stimulate insulin release and insulin sensitivity. Other formulas that contain sucrose will give about 50% of the glucose that a maltodextrin-containing formula has. But when you look at the clinical results, even though theoretically and even biochemically you see a difference, the benefit appears to be there. And remember, the problem has been that carbohydrate loading outside of protocols, of bundles, seems to work very poorly. And so whether it is more of a supplemental type of intervention, or what the exact role is there, and whether we could vary the formulas, is something that that we'll need to study further. But I do know that people use some commercial sports drinks routinely.
Okay, thank you for that. I think we'll take our last question here, and I want to sincerely thank everyone in the audience who has sent in so many. I've tried to kind of group them together as best I could, and I certainly hope I haven't missed too many. Our last question is, Dr. Ochoa, are you aware of any GI complications, such as pneumostosis intestinalis, in relationship to using immune modulating formula post-op only?
I have personally not seen pneumatosis nor read any reports after immunonutrition. I have seen pneumatosis as a result of enteral diets, particularly high volume formulas in patients. So I'm not sure that it is related to, or that if the appearance does occur, if you get a pneumatosis, if it is related to the formula or the type of formula or just the fact that you're giving enteral nutrition to those patients.
Okay. Well, I want to thank you again, Dr. Ochoa, and thank our audience today for their participation as well. So on behalf of the Nestle Nutrition Institute, we hope that you found this information valuable to your practice, and we wish you a good rest of your day. Thank you.